And even. Oh, hi Ariana.
Certainly.
Oh, no, you're fine,
Yeah.
you're fine, I can get around. See if I can. I should have done it before. Just get. Yeah, they probably sit up behind the desk for you if you want.
I'm waiting to get my registration.
Uh,
I just kind of came in and sat up here. Mine's the same way. I just left it.
Should I say that I killed a cockroach in the bathroom in the hotel room last night?
Wow.
Are you saying Bethesda?
Oh.
Wait, that's where you're staying.
Yes.
Now I'm gonna go this way so I can actually look straight at it. What? Thank you.
Hello.
Oh.
This one's like down to the bottom.
Yes, they come up. You have to, yep, use the push.
Oh. Now I'm in the top
They're
row.
all squeaky.
I'm super excited.
I
about
did
what
get
they're
it.
doing. Oh, sure.
There.
No power, old tables. Hey, Rob. Like that was the,
That was the freshman.
yeah, that's exactly right. Freshman loss was the freshman loss. They haven't yet they played.
Yeah, my own TV, I came out on Friday.
Yeah, I freaked out.
Yeah,
I went to the front desk and I said, I'm lift here. Cockroach about it. Said I took a picture. You want to see it?
She came in.
Before or after you killed it? Before. Well, it was little. I wanted to make sure that's what it was.
How are you? Leslie?
I have a terrible phobia about this too. Stemming from something that happened when I was a kid.
Director.
Yeah, I was thinking, for some reason, like, I was gonna find jobs in my, are you saying that I'm not?
Yeah.
I'm free now.
I mean, we all know.
Long retired, yes.
I do believe that. I might still be out there. Four,
Yeah.
you know.
Chris?
Yes, and Chris, but I see his name occasionally, but it's not necessarily. But anyway.
Actually, you long before it was direct seemed to be very less.
We just hit with your 6 billion messages
This one you actually.
sent since it started in 2012. So I make sure I got my buildings.
Yeah, I'm sure it's billion at this point.
And of course, now it's kind of reinventing itself for the whole email.
Sure. Yeah, it was it wasn't the vision of the future, but it was really practical.
Yes.
This can actually help, you know.
The nuts and bolts
Yeah.
approach that your everyday user could rely on.
I was at Deloitte during the high tech days.
Yeah.
We pretty much were the PMO for ONC. So back when that was passed, you know, employees at that point. And suddenly we had $6 billion to spend. And so I was basically the active fund for about 6 months while they hired people, project program officers and things for this project.
Cool experience.
And just the long conversations about the role of direction, whether, you know, whether we should be pushing for a pure form of interoperability, or whether we can say this is a legitimate step in the way. And it's not going to go away. How much fun. Think about it. There's lots of better ways to do this. Information exchange. They are still essential in certain settings, situations, and not ready to be thrown out yet. And so.
Just working with some behavioral health providers. You know, we didn't get paid that much.
That's right.
We're trying to figure out, and we still have plenty of areas in our industry that needs to come along.
Yeah, well, there was maybe we'll have another global financial crisis, and you know, stuff a bunch of money into the economy. No, I'm kidding, but you know, it was, we just do it much more rational by this time.
That would be rational anyway.
Yeah. there were too many, I mean, especially at that point, the spending on the healthcare economy was this dual, so rather than always doing things in the right order, it was do it fine. Don't spend, it's okay, we don't want to fill it in again. I mean, you ideally wanted to do something that had a big impact. As you can see, we're still sort of cleaning up the mess of how that played out. There was, how else we were gonna do it.
Sorry, are any of you, do you know if anyone else from your end of things is coming?
No, not
Is anyone else?
That I know.
I'm just.
Cool. Okay, well, folks online, I think we're gonna go ahead and get started. I need to keep remembering to pocket that.
Now the station.
So is that?
Yeah, I think that's picking it up. So I guess if any of the in-person speakers speak, try to aim it at the snowball thing.
We tested it actually, it was just fine when we tested it.
I asked the folks online to put their name and
the chat?
org in the chat. I think I'll have us go through just in person. Everyone here to say who they are, where they're from. Okay, Anna's the iPad. Thanks, Anna. Okay. So, hey, Rob. You ready?
Order.
Oh. Solving world's woes over here.
Well, I love that. So I think we'll just go ahead and get started. I don't wanna waste too much time and I want us to be out on time. So for folks online, I have my video on. So my name is Emma. I'm from the American Medical Association. I'm one of the co-chairs. My lovely co-chair Anna is on her iPad on the train, diligently phoning in today. So, Anna, just for you, I'll take over more of the talking, but I'll be sure to pause. I'm not sure what your audio situation is, but for any of you here tomorrow, Anna's going to be leading the coffee kickoff tomorrow morning. I'll be there with her, but you'll get a chance to see her in person. All right, so I'll go ahead and get started, but I would love for us to start off with introductions of those of us in the room, just so those online can see. So for those online, sorry, you can't see all of us. There are 1, 2, 3, 4, 5, 6, 7 of us in the room. And maybe I'll just start to my right with Rob. You want to introduce, everyone can introduce themselves, say maybe what department, what focus they have, and then their organization.
Rob Tennant with WEDI, and I am focused on everything, but very excited. We spent a lot of time at the board talking about the importance of getting the patient voice to the table. So we're thrilled that you and Anna have taken the reins, and we're very excited about the work products coming forward.
Thanks. Doing everything sounds exhausting.
It does.
Hey everyone, I'm Heather McComas from the American Medical Association. Really glad to be here and happy that WEDI is pulling the patient voice in this kind of formalized, specific way. So glad to be here.
Heather's my boss, so everybody needs to help me make my work good.
Emma's
Yes,
a
I'm-
boss.
She is awesome.
Deserves a raise.
Goodness, how do I, yes, Emma deserves a raise. just saying. Never met her, but, new to WEDI, my first time, pretty excited about that. I actually, come out of the provider space. I'm actually with Mayo Clinic, and our value is the needs of the patient come first, so we're talking about magic, right?
Great.
I lead the technology team for the revenue cycle, so all of the tech stack from e-commerce to cybersecurity.
Thanks.
Mary Lee Stein from Aetna. I'm the board chair for WEDI. So I get around a little bit. And I'm really, really excited for this work group.
Great, thank
So
you.
happy to have you.
Hi, I'm Leslie Berkey-Heiser with Direct Trust. My co-chair, Tantia Nugent from Kaiser Permanente and I are going to be speaking next at 3 o'clock on privacy security. But we've always had a lot of things in common with this work group, so I'm happy to be here today. And I have to tell you, one of the things we did on the privacy security work group is create the top 10 things for small to medium-sized organizations for cybersecurity. And whenever I present it, I say cybersecurity readiness is patient safety. So it kind of ties back to the patients.
Love that. Thanks, Leslie.
Ross Martin with Point of Care Partners. I have not my first WEDI meeting, but it's been a while since I've been here. I've done a lot of patient advocacy work in my informatics career, which goes way back to pre-high-tech stuff of the American Health Information Community, where I co-chaired a consumer empowerment work group there, and used to deliver babies in my past life. I haven't done that for about 20 years. So.
Those babies are all grown now.
They are. It's scary how grown they are. Yes.
Great. Thank you, everyone. And for those in the room and not online, I asked the virtual attendees to pop their organization as well. So I'll read some of those off. We have, says 21, but I think minus a couple of us, it's probably more like 17 or 18. So we have Dino joining from the AMA. Let's see, Kaiser Permanente, Georgia Department of Community Health, Yale Cancer Center. We've got quite the geographic spread here. Minnesota Department of Health. I went to college in Minnesota, so I love the Minnesota Department of Health. I always like crossing paths again. I saw, I think early on, someone from the ALS Foundation, ALS Association, excuse me. So thank you, everyone. And for those who are joining online, just let us know, pop it in the chat if at any point you have issues hearing us, but we can hear you. So during the discussion, I'll be sure to call out time for those who are online, since I know it's sometimes difficult to do hybrid, but I'll be sure to pause, and you can come off mute if you want, though I understand if you'd prefer to be in chat only. So you'll just be seeing me for right now, but I think once I'm done presenting, I might turn my computer around to give the virtual attendees some idea of who's in the room. So without further ado, we'll go ahead and get started. Well, I guess before we jump in, I'll reintroduce myself. I'm Emma. I'm a lead policy analyst at the AMA on Heather's team, the administrative simplifications team. The last 5 years of my career before joining the AMA, I did government affairs at a national sickle cell organization. And then before that, I worked at a local nonprofit in Chicago focused on child sexual abuse prevention. And so I've been working deeply in the patient space, patient advocacy space before this. I think in patient advocacy is often very difficult and emotional because of what a lot of patients have to manage. But I think in those two communities especially, it was very heavy, very urgent. And I think that's where my love for this work came from. So I'm now at the AMA, and I really love being able to bring my past and my current life together. So I'm so thrilled to be co-chairing this with Anna, and I have our slide in a minute, but just a reminder that we operate under the WEDI antitrust guidelines. So I did the screenshot here. All of you should be familiar with this, but just, don't share what you wouldn't share on a public lunch. So here's a picture of Anna. I know she's joining virtually on her iPad. So Anna Heis, VP of Advocacy and Access at the Arthritis Foundation. Anna, I don't know if you have the ability to come off mute, but if you want to, feel free to hop in.
I'll just quickly say hi and thank you, Emma, for leading this today.
Thanks, Anna.
Hi, Anna.
Hello. Anna and I had sort of crossed paths a little bit when I was in the rare disease community, and so it was also personally very nice to be able to co-chair with her. All right, so I'm just going to start very briefly with a recap of our last meeting in October, because I really want to just jump into the discussion today, both with those in person and those online. So our last meeting was mid-October. It was fully virtual. We had a guest presentation actually from Tantien from Privacy and Security. She and Leslie and their work group have been putting together some projects, and so they brought a couple to us for consideration. I listed them here, but keep them in the back of your mind because we'll come back to that during our discussion. And then we had a group brainstorm on how to prioritize some first projects, coming up with additional ideas. I quickly listed all of the projects we discussed there, and I'm happy to share these slides after. And then we touched on a little bit, we didn't have a ton of time in our last meeting, but we touched on sort of the processes of the work group just to figure out what works for everyone in terms of, what's the best way personally for you to review materials? Do you enjoy it better when it's live and you don't have to do it outside of the meeting? Do you prefer doing it outside of the meeting so you can come ready to discuss? So we have a couple things like that we'll get back into today just to solidify some workflows. I think it's really helpful to also just set expectations within the work group. So the first thing I wanted to do, even though I don't think this will necessarily be the final group, I just wanted to pull up our charter here, and I'm not going to go through it word for word. But I wanted to just touch base and see if anyone had any edits they wanted to make. So I'll just sort of read off some of it. Anna and I and WEDI have imagined the purpose of this work group to focus primarily on healthcare business processes and challenges related to workflow for improving the patient experience. And so I think while all of us in our particular roles might not be fully focused on the patient advocacy side of our organizations, it is important that we bring that context to our discussions when we're here. So we're hoping to promote adoption of electronic transactions, to promote patient-centeredness, and that comes into the picture in a million different ways. I love to always say that it is incredibly easy to center patients, but it's not always done. And I think the exciting thing is that there are many different ways to do it. Obviously, we'd also like to bring visibility to the patient perspectives across WEDI work groups and initiatives. And so in that context, we'll just be sort of a sounding board for other work groups, provide the patient perspective on their deliverables, either in full collaboration or maybe just as a quick review. What I have in the blue box here, this is generally sort of the pro forma stuff that's on WEDI workgroup charter. So nothing here is really out of the ordinary. Just talking about adhering to policies, reporting back to leadership, bring sort of agnostic solutions to the table, participate in other meetings through WEDI. The goals, like I said, are very similar to sort of the purpose, providing a forum for all of us to come together to talk about how we can solve these problems from the perspective of patients, and then also ensure that the patient voice is coming into the discussion. So Anna and I are actively recruiting through patient orgs, we know, and I know we have a couple patient orgs online today, so that's super exciting. So I'll keep going here. Again, the sort of out of scope, the top two bullets are pro forma from the WEDI charters generally. So we're not going to provide interpretations of specifications of transactions or operating rules. And we're not really going to talk about transactions not related to healthcare. And then back to the blue boxes at the bottom, sort of predictable things here, how we're going to measure our success on various points. Obviously hosting calls, promoting interactive discussion, creating work products, making sure that the work products are helpful, not duplicative, things like that. And then especially when we come to development of educational work products, Anna and I are going to try very, very hard to work directly with the patient community. And that's why it's so important to us to get those voices in the room. Because obviously if you're putting out a best practice or a one-pager for a specific audience, you want to make sure that it's helpful for that audience. And so they should be part of the design as well. And then lastly, just reporting back to WEDI work group leadership on our activities, which comes as no surprise to anyone here. Are there any questions on the charter? I know I blew through that kind of fast, but I want to save time for sort of the bigger discussions. Anything seem like it's glaringly missing or needs to be edited? I will take the silence as support. Great. So now we can accept this charter as finalized. That's very exciting. And this work group has already done its first deliverable. Love that. Wow. Okay. So now into the more exciting things where we're going to do a little bit more of discussion. I'm actually going to hop up and get that thing out of the way here so you guys can see. So up on the screen now, I pulled up the top 6 projects we came up with. Each one has a 1 to 2 sentence description. My aim is to right now identify 1 to 3 that we can just cement as this is what we're going to do. I went through and just on a very basic level, estimated the level of effort. You can't really see the color coding. I love color coding, which I think people here will learn. But if you're in person, you cannot see the color coding on the screen. But I've just basically separated them out into low, medium, and high level of effort. And then furthest to the right, you'll see any other work group, anything listed under lead is a WEDI work group. So 3 of them we imagined leading with inpatient experience. And then there are 3, the first 3 were ideas brought to us from other task groups or that might involve other task groups. Obviously, as projects evolve and grow, we might spot collaboration we didn't necessarily see right off the bat. So I'll go through them just from the top to the bottom. So the first 2 came from Leslie and Tantian. Actually, Leslie, you're here. Would you like to just give a brief recap? I know Tantian, talked about them in depth last meeting, but you're here, so might as well.
So the first one has been on our list, privacy and security, for a couple of years now, as we've been watching. Really started with the CMS patient access rules and the whole of interoperability taking on, the role that it has. And the fact that organizations are supposed to make sure that patients in the future, if not already, depending on what kinds of insurance they're subject to, et cetera, able to get their own data on their mobile phones and just ask for it, which is absolutely still huge today. If you're in the provider office, it's still a surprise to say, how can I get this? I want to see it on my phone. And they're just not ready for it. Anyway, we really believe that there is a need here to help explain to patients, and maybe it's through their providers, we don't know how, to help people understand when they can trust whatever the end device is that they're using. Some way to know, oh, this has been vetted by a third party, or this has the old-fashioned good housekeeping seal, or is it the VeriSign checkbox? You just think about what is it that we can teach our patients, and maybe it's our doctors to teach our patients how they can trust that they can really not get themselves in trouble, especially given cybersecurity attacks and everything everybody goes through. So I think that one is really high on our list. We just can't figure out how to crack it. The second one that is high, and I'm glad to see it's high, is to explore the role of digital wallets in healthcare. This is because the latest NIST 863 version 4 just came out on identity. And in it is a consumer digital wallet. So just like we go and get our tickets at the airlines right now, we put it in our wallet so we can stand in line and show our ticket. Same thing for our healthcare, being able to have, just think of it that way, a consumer wallet. While I know that's high, and I'm glad it's high on your list, I suspect it's still really incredibly early. The NIST 863 was just released, and I think they're talking about a year to take comments on it. So I don't know if that plays into your planning, but I'm thinking that one's going to be out there for a while, even though I'm glad you recognize it as high as we do as well.
Yeah, and I think that one also, I think both of them, privacy and security, will always also have a high effort associated with them, because anything privacy and security is going to go through so many reviews with various entities as well. Thanks, Leslie. And I know I brought this up last time, but for the digital wallets, every time I think about it, and this was top of mind because I've had a physical DC Metro card for years, but I always forget when I come here, I'm from Chicago, that you have to beep on the way out. And so I always beep on the way in, put it away, and then I'm trying to rush out, and then I have to dig it out, and I just put it in my wallet over lunch. And so I'm very excited that I no longer have to dig in my backpack on both ends of the trip. Tantian.
Or just get out the phone.
She has
Like
a
the
comment.
best thing that ever happened.
Yes,
I never have to go in my wallet.
totally. Tantian, you are unmuted?
Yes, I am unmuted. Can you hear me?
Yes.
Yes, just to add on to the second, regarding digital wallet, which comes from this 863, there is also very recently the Current Alliance released their digital identity credential standards, I think. So that's something I'm also looking at, and Leslie, I'll talk with you offline as well, but it's sort of working in the similar arena of digital identity, how do we enable that? What are the security around that? And also making sure that it's accessible and it doesn't, what's the word, exclude certain population. It's
Right.
needing the healthcare, access to healthcare services.
Well, it's really clear as interoperability gains more foothold, being able to know the right person at the right time. It's the same old integrity. But you're right, Tantian, there is a lot happening in this space. So when
Yeah.
you evaluate, because when we do this in the privacy security work group, we look at the estimate, but we also look at, sometimes we look for the low hanging fruit.
Yeah.
So we can also say, is this one that we could knock out quickly and easily
Yeah.
get some motion? So I just see that one as being a really big deal,
Mhm.
high, but probably taking us in a few years.
Yeah, a very much a long game.
Whereas if we could get something out soon on the whole health app thing about patience and trust, that seems like it's now
Mhm.
to me, but
Yeah.
anyway.
No, that's helpful. Mark, you've got your hand up.
Hey there. I put in the chat, the Karen Alliance is actively working on the creation of a digital insurance card implementation guide, a new version. I'm actually working as the author on that project. So that will effectively enable think of it as your coverage card for your health plan being available in the wallet on your phone. And we are looking at various use cases. So it can also include having a QR code that could be printed out that allows you to grant access to your coverage and potentially other related information.
Got it. Thank you, Mark. Do you, for the digital insurance card, you may not have an answer to this, but do you have a rough timeline for that? Are you thinking, you're gonna try and test in a couple years, test on a much shorter timeline? Do you have an idea?
It'll be a much shorter timeline. I'm being effectively pushed. We probably want to get the implementation guide update probably published sometime in the first quarter next year.
Oh, okay. Yeah, so very imminent.
Did Mark mention that's Karen Alliance?
Yes.
That's it?
Yes, it is.
Rob, what are your thoughts about identity within WEDI and our work groups? And
Well,
it's a big one, isn't it?
well, we've looked at this issue for years and years, and we had a virtual clipboard project that actually I co-chaired when I was on the board. And much like what Mark just said, I mean, it was the idea was you could walk into your doctor's office, they would scan your card and they'd have the ability to do an eligibility inquiry off of it. They would be able to capture some key data elements. And one of the things that, and we had a patient experience council that we relied on, and they talked about the importance of being able to capture current, chronic illnesses, but also the drugs you're on. Because, when the classic case of you're sitting there in the waiting room with the clipboard on your lap, trying to remember, well, it's a purple pill. I don't know exactly what it is, or at least I can't spell it. This way, there'd be no mistakes, because providers take that information from the clipboard and they type it in their EHR, and that becomes the record, whether or not it's accurate. So we looked at this, and unfortunately, we weren't able to get traction with all the key players. I think we were probably 5 years too early or so, because this is back in 2015. So I think this is an outstanding opportunity, leveraging APIs. Patients are more comfortable with a smartphone, even older patients and caregivers. So huge opportunity, and it might involve, several of the work groups as well.
Well, it seems like sometimes the newer things get picked up by the emerging technologies work group first.
Yes.
So I didn't know if you thought that's where identity might come in, or if it falls in privacy security. It clearly crosses so many places, like it crosses this one too. So.
Yeah, and we were working with a group, I think, Parent Alliance was involved. There was an effort made to create a standardized approach. Again, it didn't really go anywhere, but there's also the patient identification issue which is part of HIPAA, but has been put on hold through the efforts of a few folks on the Hill. Should that go away and we have a national patient identifier, that opens up a lot of opportunities, but I wouldn't bet the mortgage money that that's gonna be changed anytime soon, so.
Yeah.
So to bring it all around, oh, I'm sorry, go ahead.
Yeah, so it's, good to see Rob again, as, things sort of come full circle, so really, WEDI in fact did effectively do, what's quite similar to Kill the Clipboard before it was Kill the Clipboard. I got pulled into the work when I was HHS innovator in residence, and I always saw the virtual clipboard as a great opportunity to improve patient matching downstream, but yeah, I mean, I think there is something called IPS, which is International Patient Summary, which would allow a patient to share their medication. So it's effectively the essentials, and it's gotten quite broad adoption. It's one of the key technologies that I believe they're using for Kill the Clipboard. It's been adopted quite like Brazil's using it for their entire health IT infrastructure, and other countries are doing similar things. So I think it is worth thinking about re-engaging and or at least maybe supplementing or supporting the existing initiatives that are happening.
Yeah, that's great. Eric, whoopsies, I think you had your hand up, but maybe you got tired of waiting. Yeah, Eric, go ahead.
Sorry, I just wanted to say, I think one thing, Eric Ellsworth with Consumers Checkbook, I think I know a number of you, great to meet all of you, apologies for being late. One other thing I think factors in this is if there are multiple deployments of the technology that don't look and work the same, then the consumer will end up with a new burden of, I didn't have the app that this particular doctor's office required. So, and I think, I see that as a part of hopefully that's a topic that this work group could be part of broadly, is like, how can we do some testing or incentivization or quality measurement of that aspect of patient experience, like the sort of disconnectedness and chaoticness. So I'll just say one more thing on that with respect to the clipboard. I know many others have thought deeply about this content, but from my time on a small provider side, that one workflow contains a large number of things that, as you unpack the workflow, may go to separate places. So you actually are doing like, your assumption of financial responsibility, you're filling in insurance information, you're doing your medical history, all in that stack of forms that are on the clipboard. And just because it's one clipboard and one really annoying experience, I want to make sure that we make it obvious for patients, like how to, as we think about the patient experience and the adoption of interoperability, that we anticipate that some of those things may separate out, or they may go to different buckets, and that consumers won't always understand that that's happening. Maybe that point is not, I don't feel like it's particularly well articulated, but I'm trying to get at this kind of scatter of stuff. So I'll stop there and maybe someone else can make it work better.
Yeah, definitely, Eric. I mean, this is something that we talk a lot about from the provider perspective as well, purely on the business side of things, but it most certainly exists. If you're having that issue with, different proprietary forms, things like that, the patient is also experiencing that. So I think it's very relevant to highlight. Dan, I'll call on you, and then I want to continue moving us along to just touch on the other subjects, but Dan, go ahead.
Sure. Thank you, Emma. The thing I wanted to mention is regarding identity and the National Patient Identifier. Because of the new technology in place, because of this, particularly something being encouraged by the interoperability, CMS interoperability initiative, believe it or not, we actually don't need a National Patient Identifier anymore, because it's possible to uniquely identify a patient by the combination of a service provider, a private sector service provider that is providing the authoritative data source for the patient, place where all the data, where the clipboard initiative is being obtained, and a unique identifier within that provider. So those two combinations of things will uniquely identify a patient. They'd be able to go into any healthcare provider with those two pieces of information and reliably get that patient's data. So I've worked for many years, actually building IBM's first product before they acquired a company I was working on to do patient identification. So I've been really frustrated for a long time for the lack of identifier, but I'm really gratified to see now that we don't actually need it. We were able to reliably identify patients with the independent initiatives that are all being done now.
Thanks, Dan. Okay, I'm gonna sort of cut us off for discussion on those two, because I want to chat through the others. Again, the goal today is just to pick which one we want to start working on, and I think a lot of points raised will be a part of the discussion for the ones that are chosen. I did see a couple questions in there about, how or when would we be seeking input from patients on these ideas, or just in prioritizing, and so that is a huge part of it, and I think part of that will be recruitment to this work group, and being able to have folks from patient advocacy orgs within the work group. But I think part of it will also be in our outreach and just sort of, through our work. Anna and I have lots of connections with patient orgs, and a question I have for all of you later is, do any of you, are you involved with patient orgs? Because I want to make sure the information is going out and coming in. When I was working at patient org, we were often approached by, at that point, mostly pharmaceutical companies who were maybe launching a new product or launching a new support service for patients. And before they designed it, it started with a focus group with patients and caregivers. And I think that's a huge part of patient centeredness, is, like I said before, including them in the design of what you're doing. So definitely rest assured, everyone here, we will be taking things slow enough to be able to prioritize that on a timeline that makes sense for the patient advocates or their representatives who are participating. All right, so just to touch on these last four, these last four ideas, Anna and I had thought about, perhaps in collaboration with the No Surprises task group, exploring from the patient community side of things, how they are experiencing the newly implemented No Surprises Act requirements currently for uninsured and self-pay patients. And this would be mostly from the patient side, right? We would not be focusing on, what issues are providers having, what issues are insurers having. We would want to learn what issues are patients having to let that inform what providers and insurers are talking about in their own problem solving. This would include direct outreach with an ultimate idea, maybe an info sheet or a simple questionnaire that we could, a very low burden, simple questionnaire that we could disperse with patient advocacy organizations with whom we have relationships to get feedback on that. I think that particularly would be a pretty low level of effort that would be a mostly helpful info gathering. But I think it would be pretty achievable because we're not imagining it as something huge.
That would be great input to the task group as well.
Yes. Yeah,
which I think would
absolutely.
be really valuable information.
Yeah, we have, just in case there's anyone else from the task group, we haven't officially pitched this to you yet. So if we do decide to do this, it will become an official pitch in collaboration. I would imagine in kind of 50-50 collaboration with the No Surprises Act task group. So the next three were ideas that Anna and I came up with, partly from discussion, partly on our own, that would be led by this work group. Two of them are kind of medium level of effort. One is a higher level of effort. And in our last discussion, someone mentioned that there is, I think, a flow to these last three that would make more sense. They thought that maybe a project on UX design should precede the API project and the info blocking project. So I listed them in that order. An idea would be to produce a one-pager on UX design, so user experience design, for vendors from the patient population. How our design features working for patients, are the vendors asking if they're working for patients, and just learning in the development of a new app or a new process, how are the vendors collecting patient feedback? That would be a part of it. So like I said, it's a little bit ambiguous, but that would be the gist. Eric, go ahead.
Sorry. Yeah, I think there's a kind of um some form of quality oversight here. So what I observe is that a lot of it depends on both the vendor's design intent and how things were deployed into production. So just to give a brief example, I recently went through an appointment sign up form that had an enormous list of racial identity elements. So large that I couldn't find mine. And I think the intent was really to be inclusive, but the effect didn't seem like that. And I suspect that, and I'm pretty good with those lists, and I suspect that people who are less good with them might have gotten lost. So I don't know if you think of that, like it's a little bit, so in addition to talking about the developers, I think there's some component of it where it is, how does that translate into deployments for different providers or other players who use those apps? I don't know if you think of that in there, but that's what I want to add.
Yeah, that's a good point. And I think that also, I imagine, well, do you know off the top of your head, were you doing that on your phone or on a computer? What you just described?
I was on my phone. I mean, the list was 300 elements, so it would have been, I think what had happened, for example, is just they named a whole bunch of Native American tribes, which is great. I'm glad that they're asking people that in terms of their identity. It just made it really hard to traverse the list, and I don't think it would have been much easier on a computer, maybe a little easier, but absolutely, yes, on my phone.
Yeah, no, that's a great point, and I think part of that too. I mean, I imagine vendors have testing teams that are hitting on, 9 of the 10 top questions for how best to design the user experience. But part of the question could be, from the patient perspective, what would they expect for ease of access on their phone versus their computer? I know sometimes if I'm doing something slightly more complicated, I'll just do it on my computer. That could be a part of it. Part of it could be changing the search function on the phone versus the computer, things like that could make the experience a little better. But that's a great point, Eric. So we've sort of touched on these last two. It looks like it's kind of getting cut off. Sorry about that. I don't know if the online folks can see the bottom of the one pager. No? Okay. Well,
It ends with following a patient.
that's why it's good. I'll be able to send it to you later. So it ends with established template for payer-to-payer communication following a patient request. This is talking about, identifying how payers communicate after a patient requests to send records somewhere that's related to new APIs. Obviously, many of these topics are being discussed in different ways, in different contexts by different people. And something Anna and I have talked about and prioritized is when we launch a new project, make sure we're also taking the time to discover what is already being done. One of my personally least favorite things is duplicative efforts. I am a non-lover of inefficiency. And so I think that's going to be a huge part of it too. So even though we're just touching on the very, very basic aspects of these ideas, know that that'll go into it as well. So I'm actually kind of curious. For those online, it'll be pretty easy for you. If you could vote for one project, if you could just put it in the chat, which one would it be? And then for those in the room, I don't know if we just do a quick little hand raise. Let's pick one. If I'll just read through them and then you can vote in the room and we'll take note of this. So if we were to pick one project right now to do, I'll kind of bundle the privacy and security ones. Would it be one of the privacy and security ones? Would it be the no surprises one or one of the patient engagement ones? Maybe we'll break it up into those 3. So Leslie, I know which way you're gonna vote. So let's start with privacy and security. Okay, we've got 1, 2, 3, 4, 5, 6 hands. Okay, for privacy and security. Any thoughts on the no surprises task group idea? That's kind of its own bucket right now. Okay, no hands in the room. I'll check online in a second. And then the last bucket would be one of the patient engagement projects, likely beginning with UX design. No hands in the room. Let me look online.
The digital wallet.
Yeah, did we,
Are you
where did
able
we
to
put digital
pop
wallet?
chart Scott
Put
up?
them together.
Privacy and security, it does say
together.
privacy
But
and
it's the people
security.
online are saying voting for the digital wallet.
Well, that's privacy and security.
I
It's
thought
under-
digital wallet was in format TBD.
Yeah, that's right.
Well, it does, but it's under privacy and security as a topic.
Yeah.
If you look under the right-hand column.
You
Under
just
leave.
put the groups together for the voting, that's what happened. So if you said
It's two-
privacy and security or like
Yeah,
you said, the
yeah.
TBD, you're voting the same.
Yeah.
Yeah. Okay. So Anna, I think we can take that to mean, let's go ahead. Maybe in our next work group meeting, we'll talk with privacy security as well. We can decide which one we want to start. I think because both of those are slightly more long-term, it would be great if we picked a short-term one to be concurrent with that. So let's say we've picked our first. So in terms of the short-term options, which would be the No Surprises project, probably the UX design.
What about the information blocking? I mean, all I think we have right now from the
Yeah.
OIG is there's 1,420 complaints. Can we tell if they're from people? Is that what you were thinking of doing with that angle? Is to
Yeah.
go to the patients to kind of, I don't know, find out what it is about?
Yeah, what they know, what they don't know.
I'm
things
just
like
thinking that might be, it's of great interest and it's current. It's just, and it might be shorter because it's a confined number right
Yeah.
now. But I don't know how much information we can get from that. Does anybody else know the OIG numbers?
I mean, I was late, I apologize, but, I don't think that there's like more granular level detail for any of that.
That's what I was
And
trying
that's
to
something that we've been asking for in different ways for several years. I mean, there are the number of complaints that are on there. It's currently not, First of all, it's not being updated. The government shut down and it's not even an active website now as they've like shut down all the ONC website functionalities. So, but I do agree, like asking patients about their knowledge related to information blocking would be good. And I think would be helpful as we think about it. I know we do have a WEDI conference call coming up December 2nd or 3rd. That's going to discuss like information blocking. So maybe that's like the kickoff to some sort of broader discussion next week on this.
Well, I know that these are the ones that we've identified. I'm wondering if there's a different one short term, which is standing up that patient advisory group and then asking them what theirs are. And then out of that, there might be some short wins or short-term wins that we can identify while we work on some of these long-term ones.
That's practical. So you're suggesting stand up the group and then we could come back to them with numerous things.
Yeah. Yeah, I like that. I hope everyone online was able to hear that. So we had a suggestion for, oh, this happens every time I scroll. Sorry guys, spoiler alerts. A suggestion to just go ahead and start up the patient advisory committee, come up, name TBD to ensure that the selection of our first projects include the patient community. I know that we have a couple folks on the call today from patient communities. So we have an idea, some from the chat, Rich Brennan, VP Federal Affairs, ALS Association. Rich, I don't know if you want to come off mute and give your 2 cents. I know you put in the chat, patient engagement, prior authorization template. If you want to shed a little light on that comment.
See if I can get it off the, here we go. Good afternoon, everybody. So from what I'm doing, I'm trying to align several, I guess, federal projects with the patient community. And one of the things that we see online and dealing with daily are access issues. And so we've been dealing with this through prior authorization. There's as everybody, most people on the know, probably already know, that there's be an application of electronic prior authorization and refinement of that space. Prior authorization is part of the utilization management component, where patients, providers, payers make a determination on whether or not somebody can have a service, medical access to medical equipment, or even access to drugs. And it's got a huge space as far as place to deliver electronically. It's going to be be supported by APIs. That work is happening at HHS level. And so I thought that WEDI would be a good place for this to sort of align, especially this committee, to align WEDI's efforts in general on the APIs with regard to prior authorization, and also having a patient voice as part of that. So I think it's a larger project than necessarily what you guys have lined up as far as today's menu. But I just wanted to make sure everybody's aware that this is going to be a huge undertaking, and we really do need every place to put patients first, and have them hear from patient advocacy organizations. So that's why I'm here.
Yeah, super important. Thanks, Rich. And I see Linnell, the little +1 in the chat. Linnell is a forever patient advocate, and Anna liked it as well. I appreciate you coming off mute to share more. All right, in the interest of time, I'm going to keep us moving forward. We only have 8 minutes left, so we'll come back to the group, and I encourage all of you who, thought this discussion was interesting and intriguing to continue coming back. We'll finalize that discussion, but we'll go ahead and determine, Leslie, you're here, Tantian, you're listening. Let's connect, and we'll pick one of the privacy and security collaborations, move forward with that, and then it sounds like the patient experience work group will pick another more short-term, more actionable, more immediate approach, potentially the patient advisory committee, or something else. So the next thing I want to touch on in the last few minutes is just some of the processes I mentioned. So I'll move through this kind of quickly just to do a quick survey of those of us in the room, those of us online. So Anna and I are hoping to develop a process to share and utilize deliverables, and a feedback loop to know when products are utilized. So this is aimed at participants of this work group, largely more of our techie stakeholders, vendors, any payers, anyone else. When we produce a deliverable, are they having an impact in your organization? Let's say it's to inform the design of an app. I'm going very basic here, but to inform the design of an app from the patient perspective, and we produce a best practices sheet or have a training on it, how is that being used in your org? Is it impactful? I'm curious, those of you who that sort of thing would apply to, do you have a process like that where you would share things like that in your organization and immediately utilize them? And if so, we'd love to know about it so that we can keep that in mind when we're producing things. I'll give a pause here in case anyone online has a response to that. If we don't have an immediate response, I'm just sort of hoping to get info on that in the next couple weeks. If your organization, the business you work with, works on this sort of external thing, how does that get folded back into your actual processes?
Yeah, I raised my hand because my concern is the feedback loop for those of you who know me and know active with the Blues for 22 years. At all the major payers, everything we do is like with a 1, 2, 3 year horizon, and the feds work the same way. So I worry that you're talking about a feedback loop when the people that do the work, they're like a year and a half out. So you're trying to influence stuff for which there's no process to react that fast, except in the smallest of vendors. That's their strength. they can do stuff really fast, but they can't do it across the whole country. But you want to do something across the whole country, and the people that can do it across the whole country, we can't. We're like a destroyer. It takes 8 miles to turn. So I think we've got to disconnect on. Now, don't get me wrong. When AI is fully embraced in a couple of years, yeah, we can turn on a dime, but that's not now. So I worry about the mismatch on the time of large vendors, large payers, and large health systems. There's no such thing as immediate feedback. Our back end systems are too slow for right now. At least that's one opinion.
Yeah, no, that's a great point. And I don't know if I said immediate feedback. We're not necessarily looking for we're not looking for an immediate report out on the end of the project and how the project went. I'm mainly trying to describe a situation where, you know, the one pager, the hopefully helpful deliverable we're creating in this work group gets folded into the process, and purely knowing, you know, do we think it'll get folded into the process? Because what we don't want to produce is a one pager aimed at vendors that vendors do not find useful and will not fold into the process. You know, that's just sort of an example. So we're definitely not looking for an immediate feedback loop, but just sort of, you know, making sure we're not in an echo chamber of producing best practices that aren't useful.
My gut from having worked with a lot of different vendors is they probably hold that information confidential and
pretty
wouldn't want to
close.
share it.
Yeah, and that would be internal. Okay.
Yeah, but this is, and I was trying to think in my head, like, really overall approval processes, but I was wondering, because really there isn't any healthcare without patients. I'm wondering if there would be a new process thing where the patient experience work group could or should review new WEDI resources before they're finalized. And some of the things might be very techy and might not really have direct patient input, but I just wonder if that would be a nice flavor, like having that lens on all WEDI work products. And I'm trying to think of where the patient experience sits in the, oh, because you're higher than a sub-work group, so you're not on your data exchange, but
yeah,
it seems like that would be nice to have like the patient viewpoint looking at all WEDI tools. And there might not be something on some things that are too kind of techy wonky, but I wonder if that's something that could be incorporated into WEDI work process.
yeah, for sure. I wonder if
Time check-in.
Yep, I am on it. Also, for some reason, my computer says it's almost out of battery, even though it's plugged in, so sorry. This was, okay, so yeah, the inter-work group collaboration, that brings me to my second point. I think we'll push this to next time. I want to find out, you know, who among the attendees, recurring attendees of this work group participates in others, so that we know, like, hey, can you check with this work group? We'll have a point person. And that we will also have ears on the ground, boots on the ground, to hear from those work groups, hey, they have a work product coming, let's slate it for review from our perspective. So that's definitely part of it, and Rob and other folks from WEDI have brought that up as one of the hopes of this work group. And then the last thing I want all of us to think about, you can put this in the chat, or email us, bring it to the next work group, is among those folks here, I guess those who are not from patient advocacy organizations, because we see that association, who among attendees has relationships with patient advocacy organizations, even if it's just subscribing to a newsletter, so that you know what they're working on. We're curious on putting together a feeler for that sort of thing. So Tantian, you have your hand raised?
Yes, a very quick question to ask for clarification, please. I'm seeing patient experience work group and I also see patient engagement. Is that the same work group?
Did I say patient engagement somewhere?
Yes, it's on the first one when we were looking at potential things to prioritize.
Okay, patient experience is the is the term.
Okay,
Thanks
my
so much.
apology. Okay, thank you.
Yeah. All right, I'm gonna go ahead and stop sharing. I think that's going to bring us to time. We have 1 minute left. Any parting thoughts in the room?
Excellent discussion.
Well done.
Great. I wasn't asking for that, but thank you everyone for coming. I hope you continue to join. And for those of you in patient advocacy organizations, please do think about others in your network who could join. I know from my days working in patient advocacy, it was extremely difficult to prioritize time and resources and staff. And Anna and I are very sensitive to that. And so we really want this to be worth your while, because your input especially is incredibly important. And so think about if there are any orgs who have the ability to dedicate time and staff to this. Thank you so much and have a great day.
Well done.